Hello, my name is Faustine Ong. I'm one of the Hematology Oncology Fellow at Moffitt Cancer Center. I'm here today at ASH 2024 to present my poster with title of Disparities in AML Survival in the Targeted Therapy Era. And this is a real-world evidence of enhanced equity of outcomes for patients in medically underserved areas. So as we know that the survival outcomes of elderly patients with acute myeloid leukemia have improved since the approval of venetoclax and hypomethylating agents or HMA. Now, as you know that in the past, it's like induction heavy, it's requiring inpatient, so resource-wise, very heavy. But now, with the advent of venetoclax and HMA, in the community, we can do it as an outpatient. So we are looking whether this provide opportunity to bridge the gap between the medically underserved area or not. So this is basically a retrospective analysis of patients with AML who were diagnosed between November 2017 and June 2023 and received venetoclax HMA as a frontline therapy. We divided into two groups, so medically underserved area or MUA or not, and this is based on their residential address. Now let's take a look about our baseline characteristic here. We can see that most of our patients population are older adult with median age of 75, and the distribution between the gender between two groups are balanced. In the race, we can see that it's mostly dominated by white patients. Okay, there is no difference in the distribution of bone marrow blasts, AML type, and even prior HMA exposure for a preceding heme malignancy. Of note, even though they're in the MUA cohort, 28% of them also received at least one cycle of HMA ven at our institution. In regards to the cytogenetic risk, there is no difference between two groups. And on the best hematologic response, most of them receive CRI here on both groups, followed by CR and MLFS, and some of them are also refractory. But there is no difference between two groups. Also, there is no difference between how many patients who proceed to receive allogenic stem cell transplantation. And also now let's see about the survival outcome. We can see here that the outcome between the MUA group and non-MUA group are basically the same, which is reassuring. Interestingly, here we can see that actually the relapse-free survival between the patient who achieve CR, CRI, and MLFS somehow is a bit better in the medically underserved area group. We're still investigating why this happened in our data set. So in conclusion, with the outcome of overall survival being the same between two groups, it's actually reassuring that the medically underserved patients also have a non-inferior outcome to the non-medically underserved patients in the era of venetoclax HMA therapy. Now, however, we have to acknowledge that our data set mainly contain white population, which may not reflect entirely the real world or the real world underserved or disparity issue. And also some of them can drive to institutions like Moffitt to get at least one cycle of therapy. So that may affect our result. We suggest that more studies are needed to ascertain if novel therapies in AML can deliver really an equitable outcomes for patients in medically underserved area compared to the one without that medical underserved area status. Thank you so much for listening to my presentation today, and please reach out to Dr. Chen, our mentor of this project, if you have any other questions. Thank you.